Hello, my name is Nupur and the topic for today is ankle sprain. We all know that ankle sprain is very common musculoskeletal condition which is commonly seen in the normal people as well as the athletic population. The games in which it is mostly common is soccer players, volleyball players, basketball players and even in the ballet dancers. And it is the common musculoskeletal condition where trauma happens to the ligaments of the ankle, especially the lateral ligaments, and it happens because of sudden adduction or abduction force because of which the foot goes suddenly in the inversion position, and there is pain and disability followed by that violence. And it depends. The pain and disability will always depend upon the degree of the injury to the ligaments. Incidence is more in the people who have or in the athletes who have calf muscle tightness or some type of malalignment in the foot, especially the varus malalignment. Mechanism of injury for the lateral ankle sprain is mentioned here. That is, the foot suddenly goes in the inversion position when it is in plantar flexion, and the ligaments which are injured are the anterior talofibular ligament and the calcaneofibular ligament. Types, there are three types. One is the medial ankle sprain, which is the eversion injury to the ankle, and a medial ankle sprain will affect the deltoid, which is present on the medial aspect of the ankle joint, and it is very strong ligament, so it is very rare to affect the deltoid. And lateral ankle sprain is the inversion injury. Here the lateral structures, that is the ATFL and the CFL, are very weak, so lateral ankle sprain is more common. And the third is the syndesmotic sprain, which is the high ankle sprain. Coming on to the grades, there are three grades for the ligament injury. This is the grade 1. Here some fibers of the ligament are stretched. There is no instability at the ankle joint. The patient can walk properly and run properly with some difficulty, and mild pain, tenderness and swelling is positive, and there is no functional impairment. Grade 2 is the moderate ankle sprain. Here there is partial tear of the ligament, some fibers are still intact. Moderate pain, swelling and tenderness happens, some loss of joint function, mild joint instability and minor bruising is evident. Grade 3 is the severe ankle sprain. There is complete tear of the anterior talofibular and the calcaneofibular ligament. The patient will be suffering from severe swelling, ecchymosis and tenderness. There will be pain initially and later on there is no pain because even the nerve fibers are affected here. So there is a possibility that the joint will be unstable but the patient will not be having any pain, and the patient here is obviously not able to weight bear at all. So this is the picture for grade 1, grade 2 and grade 3 ankle sprain. Diagnosis, like I said, it is an inversion injury which is commonly associated with tearing sensation or the pop, which is felt by the patient over the lateral ankle, and immediately swelling will happen in grade 2 and grade 3 injuries, and X-ray is done to rule out the fracture. There are few rules for which we have to prescribe the patient to go for an X-ray, like when we will prescribe the patient to go for an X-ray, and the rules will be discussed later. MOI, that is the mechanism of injury, which is seen here in the picture. Clinical features usually, like we discussed in the grades, are pain, swelling, ecchymosis, instability, weakness of the ankle muscles, impaired proprioception of the ankle joint and activity limitations. So in the later stages of rehabilitation, we have to focus mainly on the strengthening, gait training and the proprioception exercises. So here are the Otawa ankle rules. What is Otawa ankle rules? There are few rules which have been researched, and if any one of the criteria is followed by the patient, then we have to ask the patient to go for an X-ray. If none of the criteria is followed by the patient, then if it is not necessary to go for the X-ray. So here are the Otawa ankle rules. The radiographs are indicated if the patient is having pain in the malleolar zone and any of the following criteria are met. So first one is the tenderness along the posterior edge of the distal 6 centimeters of the lateral malleolus. Second is the tenderness at the median malleolus. Third is the inability to bear the weight even for 4 steps and pain in the midfoot area. So if any one out of the 4 criteria are met, then only it is the X-ray is required, otherwise not. Differential diagnosis, here is the list. Syndesmotic injury, Achilles tendon rupture, sensory nerve injury, Lisfranc fracture, cuboid syndrome, MCL, that is medial collateral ligament sprain, and peroneal tendon tendinitis. Assessment, we have to find out the degree of instability, and if it is grade 3, obviously we have to refer it to the doctor and identify the reduction of the range of motion, how much is the strength, and if there is associated injury or especially of the fracture. So this is the special test picture. The first one is the anterior drawer test. The second one is the talar till test. Anterior drawer test is usually done to to diagnose the anterior talotibial ligament, and talar till test is done to find out whether calcaneofibular ligament is injured or not. Second one is the star excursion balance test. You can see the picture. This is very important test and we can do in all the ankle injury patients, whether it is sports injuries or normal injuries. Management is grade 1 and grade 2. We follow the first aid management. Followed by that, modalities are given. Soft tissue massage and joint mobilization of grade 1 and grade 2 is given to the patient. Because grade 1 Maitland mobilization and grade 2 Maitland mobilization is specially for pain relief. And then followed by this treatment, we give muscle strengthening. We focus on proprioceptive exercises, and in the end we focus on functional training depending upon the game of the athlete. And for grade 3 the surgical repair is done initially, and then protective bracing is given, and then muscle strengthening, proprioception exercises and functional training is done. PD management for duration of first 3 days, that is the maximum protection phase. Here price protocol, that is protection, rest, ice, compression, elevation is given to the patient. Protection is very important here because still the stage is acute stage, the joint is not stable, the ligaments are not stable enough, it has to be protected so that healing happens fast. If during this time if the protection is not done, then healing will not happen and the condition might worsen or it will delay, and patient has to be in the immobilization phase for little longer period of time. Rest is obviously needed, ice, compression with the help of the crepe bandage or the ankle binder, and part has to be elevated so that the swelling can be drained. Partial weight bearing is done with the help of the crutches, and muscle setting exercises if it is within the pain limit, and gentle mobilization to inhibit the pain, that is grade 1, grade 2 Maitland mobilization. Then next is the moderate protection phase, which is from 4 to 10 days. Here non-weight bearing is done by the patient, and or even weight bearing as tolerated by the patient can be done in this phase, and active range of motion is done uh, till the pain limit. We should not go beyond the pain limit because still healing is in process. Grade 2 mobilization of Maitland is given, toe curl exercises and seated calf raises are started, and intrinsic muscle exercises are started in the sitting position. 11 to 21 days is the minimum protection phase. Here almost healing is finished, the part is stable enough, the swelling has gone, and so weight bearing can be increased, and the return to sports option can be considered, but that is subjective and it depends from patient to patient. We can initiate the eccentric exercises, proprioception exercises, balance board exercises. The last phase is from 3 to 8 weeks, that is return to activity phase. Here increase the weight bearing as tolerated, and by this stage the patient can do full weight bearing. Agility drills are done, sport specific training as per the athlete, and perturbation training is given to the patient, and isokinetic resistance training is also started. You can see the picture of the cave bandage which we usually give before going to the sports. Like while playing, the patient can have this cave bandage on the part and then go for sports in the initial time. This is the picture of the ankle binder which has replaced the crepe bandage now. Thank you.